Hi, my name is Irfan Dhalla. I'm a general internist at St. Michael's Hospital in Toronto and also an assistant professor at the University of Toronto. I'm sorry I can't be with you in person today, but I do want to say thank you to the FDA for providing me with the opportunity to present via recorded video. These are my financial disclosures. I don't receive any payments or research funding from the pharmaceutical industry. I thought I'd start with this slide. These data from the CDC are no doubt well known to everyone in the room, and I'm sad to say that we've observed a similar increase in opioid overdose deaths over the last decade in Canada as well. I think it's fairly well accepted now that opioid-related deaths are a major problem in both of our countries, and although the numbers aren't as clear-cut, I think it is also accepted that addiction to prescription opioids has become much more common than it was a decade ago, and this too is a major problem. Of course, prescription opioids are not the only substance people can become addicted to, but what separates opioids from heroin, cocaine, tobacco, or alcohol is that prescription opioids are licensed pharmaceutical products produced by pharmaceutical companies, distributed to pharmacies and hospitals, prescribed by physicians, and ultimately used by our patients. So when we look at a slide like this, one of the key questions we should ask ourselves is there a relationship between opioid prescribing and opioid overdose death? The answer, of course, is yes. Here, for example, is a figure from a recent article in JAMA. The three lines represent opioid overdose fatalities, opioid sales, and treatment admissions to opioid addiction programs, and you can see that all three lines basically increase in lockstep. In addition to the temporal correlation, we've also observed geographic correlations. In parts of the world where opioid prescribing is frequent, opioid death rates are higher than average. We've observed geographic correlations not only when we look at different countries, but also when we look at different states within the United States and when we look at different counties within Ontario. My colleague Tara Gomes has also shown that the risk of death increases with the dose that is prescribed, and Michael von Korff and his colleagues in Washington State have observed a similar phenomenon. So we see temporal correlations, geographic correlations, and correlations with the dose that is prescribed. Another important question we could ask ourselves when we think about whether the FDA should do anything about the label is whether people who die of opioid overdose are obtaining their opioids via prescription. We've done some work to answer this question in Ontario. We've gone through thousands of files at the coroner's office abstracting information about every opioid overdose death, and we've linked each death record to healthcare administrative data. What we found is that people who die of opioid overdose are indeed frequent users of the healthcare system. 2/3 of people who died of an opioid overdose saw a doctor within a month of death, and virtually everyone had seen a doctor within the year before death. The median number of doctor visits in the year before death was 15. To me, that's an astounding number. I would bet that very few people in the room have seen a doctor 15 times in the last year. We also found that most people who die from an opioid overdose were recently prescribed an opioid by a physician. In our study, more than 4 out of 5 people who died had received a prescription in the year before death, and most people had received 10 or more such prescriptions. This doesn't exclude the possibility that some of these individuals were also obtaining opioids illegally. Undoubtedly some were. But our data clearly indicate that physicians have an opportunity to reduce the number of opioid deaths by prescribing opioids more carefully. I should note that we are not the only researchers that have observed this phenomenon. Researchers in Utah, for example, have done a study of people who died of opioid overdose, and in their study they found that the primary source of opioids was healthcare providers in more than 90% of cases. The other key question we have to ask when we think about what the FDA could do is this: how effective are opioids compared to other treatments in the setting of chronic non-cancer pain? Even in the most carefully selected and monitored patients, i.e. those who were enrolled in randomized controlled trials, opioids are at best only marginally better than placebo and probably no better than non-opioid treatments. Here, for example, are the data from the Cochrane Systematic Review of Opioids for Osteoarthritis. The review authors concluded when they saw these data that opioids should not routinely be used even if pain is severe. And here are the data from the Cochrane Review for back pain. The review authors concluded that the benefits of opioids remained questionable. In the real world, things look even less favorable for opioids than they do in RCTs. Opioids cause more falls and deaths than non-steroidal anti-inflammatory drugs in the elderly. Up to 1/3 of patients who are prescribed opioids for chronic non-cancer pain meet criteria for an opioid use disorder, what many people would call addiction. And functional outcomes in opioid users are worse than functional outcomes in NSAID users. These studies, of course, are subject to all of the usual limitations we attach to observational studies. But I think it's safe to say that the preponderance of evidence supports the following 4 conclusions. Number 1, prescription opioids do harm a lot of people. Number 2, most people who are harmed by prescription opioids are in fact being prescribed the drugs. Number 3, the evidence for the long-term effectiveness of opioids in the setting of chronic non-cancer pain is very weak. Number 4, the current regulatory regime is not working. I'm therefore very grateful that the FDA is holding these hearings and considering how it might change the situation. And I'm also grateful for the work that the FDA has done so far in addressing the prescription opioid problem. And I look forward to hearing what the FDA's next steps will be. If anyone wants to contact me, please feel free, and thank you very much for listening.